Hi, I'm Dr. Kevin Milo, one of the co-hosts of the Physician Empowerment Podcast. At Physician Empowerment, we're dedicated to improving the lives of Canadian physicians, personally, professionally, and financially. If you're loving what you're listening to, let us know. We always want to hear your feedback. Connect with us. If you want to go further, we've got outstanding programming both in person and online. So look us up. But regardless, we hope you really enjoy this episode. Hi, everyone. I am Kevin Milo with the Physician Empowerment Podcast, and I am very, very glad to be joined today by Jayna Amadasun, who we're going to get talking here in a second, but I'm going to just start with this kind of long-winded introduction because Jayna and I connected. We had a Zoom call a few days prior to this recording, and it was truly, truly remarkable because we just got talking. And it was one of those things that's like, oh, maybe we'll end up talking for 20 or 30 minutes. And I think it was over an hour that we went on. And the reason why we connected and really dive deep is because there were so many issues that came up when we were discussing the healthcare system. And it was remarkable to hear it from Jayna's perspective. So here's Jayna's background. Jayna is an MD by training, having acquired her degree in the Dominican Republic, having trained in the US, but now here in Canada, she works as an ethical strategist and consultant. She does coaching for Black medical practitioners and healthcare professionals. She carries a master's of law in medical law and ethics with merit from the University of Edinburgh. So, Jayna, you are just a dynamo in this space of, our public healthcare system, right? And what's also fascinating is you come from an outside perspective because prior to your MD, you had worked years as an RN in the Bahamas, including the emergency department, including flight medicine. Like, you've seen it all, you've done so much. And now you can engage on these policy levels, having understood the healthcare system from the ground up and seen it in different jurisdictions. So, Jayna, what we want to cover today, and I think we're going to be getting you back on the show again at some point in the future, is burnout in frontline healthcare workers. Because this is what you deal in, this is what you know, this is what you've seen. And this isn't just doctors. We're talking about our nursing staff as well and other people that are involved in direct patient care. So that's my long-winded introduction to what is an episode that, in my opinion, is going to represent a highlight of my podcasting career, because this is just too important to ignore any longer. So go ahead and share some of your insights, and we're going to just go with this.
Kevin, thank you so much for having me on this podcast today. I'm really excited because in this ethical space that I'm in, the ethics is the elephant in the room. Nobody wants to talk about it except me. And how do you apply it to what frontline healthcare workers are going through? It's really about creating a just and an equitable work environment that is conducive to a worker thriving in that space. And so it's really, really important for us to have that conversation and go beyond the conversation. It's about really getting some results. We talked about it prior to starting the podcast. Our healthcare system is in a crisis. This is an unprecedented time, even outside of COVID. COVID only highlighted the realities that were already in existence. And I like to draw analogies from medicine because that's the background that I have. It's like that boil that's been festering, right? And if you leave it untreated for a long time, it explodes on you. Sometimes I've seen that happen. It explodes and a lot of gicky stuff comes out. And then sometimes it takes a long time to treat after the fact, as opposed to heading into that preventative state. We saw this coming. We could have dealt with this adequately and we could have resolved it from the beginning. And so healthcare is in that position right now. We really need to do some serious work on our healthcare system. And this work is going to come through changes in our policies and our processes that are able to support our frontline workers, our doctors, our nurses.
And sorry, that's the key.
Yes.
Because earlier on in this podcast, and I've said it for years within kind of my personal and professional circle, is that when we talk about who is the market for healthcare, who do we serve? We're always talking about patient outcomes, and obviously that's key.
Yeah.
But who achieves the patient outcomes? It is frontline staff. So if frontline staff are burnt out, exhausted, struggling to be there,
yes,
how are they going to perform in the way that they need to get those patient outcomes? So we need to start having a healthcare system that is oriented towards frontline workers. That's doctors, nurses, and others who provide patient care.
Absolutely. Let's try this analogy. And we talked about this a little before we started. The healthcare system and healthcare workers, your doctors, your nurses, your allied healthcare professionals, they are the heartbeat of your institution. If you have a patient that walks into your ER who is experiencing supraventricular tachycardia, and your listeners will know what that means. That means this is an emergency situation because your heart doesn't have the capacity to function for a sustained period of time at 240, 260, 280 beats a minute. That's impossible. Eventually, that's going to shut down. When that shuts down, your patient care is going to be adversely affected. Right now, I looked at Statistics Canada. Canada has 41 million persons living here. 6 million of those people don't have family physicians. They don't have that access to important healthcare, the important healthcare system that they need. They don't have the support. When 6 million people are sick and your healthcare system is deficient, what's going to happen? It's that heart beating very, very fast because you don't have the resources in place to support your workers to be able to support the masses of patients that need to be seen. Because when these people are not going into the family physician's office, they're going to your emergency rooms, right? And they're flooding in there, and they need to be taken care of. And so we have to refocus our attention toward healthcare workers. One thing that's really important and that I learned a long time ago in healthcare, I think this was my first introduction to healthcare when I started off as a nurse. And I was going through my nursing training, and everything was about the patient. You have to view the patient holistically. You can't take one aspect of the patient and not consider the other. And then I realized, wait, hold on. But you're not looking at me the same way as a healthcare provider. You're seeing me in this singular function, but I'm also the daughter of someone, the mother of someone, the sister of someone, the spouse of someone. I'm bringing all of this into the workspace. How are you supporting me in that? And so I thought that was very hypocritical from the onset. And I spoke about it a lot. I'm like, hey, hold on. You can't do for the patient what you're not going to do for me as a healthcare provider. And that disconnect has created a problem over time. And so what we're experiencing today is compounding. These are things that have been left out. They have not been dealt with or adequately addressed. And so now the compound effect of it is this crisis that we now find ourselves in.
Yeah, I mean, we're starting to see, and I keep hearing, because I'm in a privileged position to be able to talk to doctors across the country, right? I mean, we're in contact with many physicians across the country, through physician empowerment programming, but even just people that will email or will hop on a Zoom call with me or whatever, and you keep hearing this common theme of, I can't keep up. I'm getting tired.
Yeah.
And we see it in our nursing colleagues as well. People are starting to dread going into work.
Yes.
And that's I always held that up whenever I lectured on wellness. That's a bit of a danger sign. Mm-hmm. If you're driving into work kind of dreading what you're about to step into, that's a sign that the work environment is wrong. That's not something wrong with you.
No.
That's something wrong with the work environment.
Yes.
And I'm hearing it more and more from frontline staff. And there are some very real consequences in terms of our ability to perform, right? And I don't know if you want to touch on some of those sorts of things, like what is a frontline worker going to be doing or not doing as they're struggling with a difficult work environment where they're feeling overwhelmed.
Okay, so let's look at high-stressed environments. High-stressed environments produces huge amounts of cortisol. Cortisol is that fight, flight, freeze kind of response when we're in trouble. It's only supposed to be pulsed, right? It's not supposed to be sustained. And so you're finding your healthcare workers are having sustained level of cortisol. We know that cortisol now can increase blood pressure, can increase blood sugar, and so the physical ailments that can arise as a result of this really pressured environment where it's not letting up. We haven't been, as human beings, we're not designed to work that way. And so it's really important for our policies and our processes to reflect the fact that we have to be able to pull back. We have to be able to walk into a work environment, do what we love to do. And don't get me wrong, there are very few physicians, nurses that come into this profession that really hate it from the onset. Very few. I don't know any.
We're all here because we care and want to make a difference.
We're the people that can, and I think that may have been an issue too at the onset. We're the people that are so passionate and so dedicated. I can remember working overtime, and I'm like, when did I go to sleep? I don't even remember. So you're just there. And because you're looking at, oh, I don't want the patient to suffer. I know that we're short staffed. I can go the extra mile, but that extra mile has wear and tear on us as individuals. It has wear and tear on our mental health and our physical health.
And our relationships as well. Right? Because we're taxed. And when we go home, there isn't enough to give.
Yes.
And there's a cumulative effect of this. There's a knock-on effect.
Yes.
There's a knock-on effect. And so it's not a case of, well, I got a couple of days off and I'm better. that shouldn't even be the case. Like, you should be able, ideally, to leave your workspace feeling energized, happy, and supported in that workspace so that you can go home and feel engaged, happy, and healthy in that space as well.
Absolutely. Absolutely. And that's why the ecosystem that we work in is not supporting us. Ecosystems are there to help you to thrive, to grow, to evolve into something greater, into something better. It's not there to cause you to shrink away or to pull away from the thing that you're so passionate about. When that's happening, then we have to reevaluate where we are. And the one thing that I've found in healthcare, evidence-based medicine always talks about reevaluating the situation. Is it still working? If it's not working, what can we do to make this change?
Situational awareness. I mean, we're always talking about that in the emergency
Yes,
department. Is the
yes,
temperature rising? Are we going the wrong direction?
exactly.
And in the midst of this healthcare crisis, I feel like the alarm bells are not going off in the way they need to be going off. And this is not just acute care. It's family practice, family
Yes,
doctors that are overwhelmed because they can't get their patients into consultants. They can't get
yes,
access to diagnostic testing.
yes.
They're overwhelmed with the complexity of an aging population, and they're feeling taxed.
And the administrative
Oh,
aspect of it.
yeah,
It's
don't even get me started on the
burdensome.
paperwork that family doctors are overwhelmed with.
Yes. And this, I looked at a CNN article from September of last year. So it's fairly recent, by Jacqueline Howard. And it talks about the harsh realities of burnout. And this is the extreme end, because she's looking at the suicide rates among healthcare workers and looking at family physicians who are on salary. And for us, that would be the fee for service physicians, looking at other allied healthcare workers and seeing 34% for family medicine, family physicians. And also, you talked about it. These physicians are so burdened because of the complex needs of the patients. That growing and that aging population that has multiple healthcare challenges, multiple diagnoses, multiple medications. So we're dealing with polypharmacy. We're dealing with multiple chronic illnesses that are not being able to be adequately controlled, and not having that avenue to pass them along to the right specialist to take care of them. And so they are feeling overwhelmed. And even though this report is out of the US, there's an old adage that says, when you sneeze, I blow my nose. That means we are close enough as a country to have and experience the same level, even more so because of our smaller population, that we don't have the resources and the human resource to cover all of these things. And so this is a huge problem that we need to address. And we don't have the time to address it, because for every day that we allow this to linger, more and more healthcare workers are leaving.
And let's talk about that. Let's pivot to
Mm,
what does that mean,
mm,
right? Because you talked about 6 million Canadians without a family doctor, and that number is constantly rising. In
yes,
6 months, Ontario had a jump of 160,000 people.
yes.
But let me just pivot here and talk a little bit about what does this crisis manifest as?
Mm,
So, in family practice, it manifests as early retirements,
Yes.
doctors who are no longer accepting patients,
Mm-hmm.
new graduates that are refusing to take a panel. And I've heard that
Yep.
numerous times, that they just do not want to take a panel because
That's
now
right.
you've got these patients that are your responsibility, but you have no means to care for them.
Yeah.
You've got acute care nurses and doctors who, frankly, are not picking up extra shifts, whether it's call
Yeah.
or,
Yeah.
emergency department shifts. And then people have options and they're using those options. And I don't blame one single person for doing it because it's
Yeah.
not about money. Everybody always says, oh, you're leaving because the money's better in private care.
No.
You're leaving. No. That's
It's
not true.
it's the environment and the atmosphere.
People are leaving. Imagine, being a nurse and getting called some racist name or something sexist, or being treated like your server at a restaurant. Even that should never occur in a disrespectful manner.
Exactly.
And asking yourself, do I really want to keep doing this?
Yeah.
And you move on to private surgical facilities where you're treated much better.
Oh, the level
in a much
of
more
respect.
collegial, respectful environment.
Yes.
And you're not subject to that kind of abuse.
Yes.
Right? Or getting asked mandated overtime.
Yes.
I struggle with mandated overtime for frontline staff. Like, how is that healthy or sustainable?
Yeah.
That feels like plugging, a hole in the dam.
Absolutely.
And the same goes for our physicians, right? Who, are forced to care for patients knowing that patient needs to get in for an OR right away and can't.
Yeah.
Right? Or this patient shouldn't be getting discharged, but you're under pressure to do it because there's a bed shortage.
Yeah.
Those are the reasons people are quitting. Everybody always says, oh, the money's better in the private sector. That's why people are leaving. No. The issue is working conditions. And it is the onus of our public healthcare system, which I am a deep supporter of. I am not a supporter of private healthcare. I'm a deep supporter of public healthcare. But the onus is on us to have better working conditions so that not only do people want to stay, but they're really engaged and not just checked out and going through the motions, because I think that is key as well.
And that speaks, Kevin, to having a just and an equitable working environment. Just in that I can say to my employer, this really doesn't work for me. My employer understands that, hey, it shouldn't be an all or none. If you have an all or none situation where your nurses have to comply, like you said, mandated, you have to do the overtime. If you don't do the overtime, you can't work here. What's going to happen? They're not going to work there. They're going to be there until they find the next thing that's going to accommodate. Because remember, we talked just a little bit about COVID on our way in here today. The COVID caused people to shift their perspective and their priorities, and where family was not maybe as high on the priority list as work, that has now changed. They want to be home at 5 o'clock to have dinner. They want to be able to tug their kids in. They don't want to miss one moment of their lives. And so, how do we support those individuals? And I do remember a time in Atlanta. When I went to school, I did a little job during my training at Emory University Hospital, and I loved the schedule. Nurses were able to select the schedules that they wanted, that worked for them. So there were nurses that only worked weekend nights. Why? Because at nighttime, kids are in bed. By the time they get up in the morning, mom is home or just about coming home. Dad is home during the night, and they're able to take the kids to school. They're able to be there for the kids after school. These things are important because these are not just physicians and nurses. You don't sign your life away because you become a doctor or you become a nurse. And so you have to be able to create balance within your organization. And they have to go back to the drawing board. They haven't been doing a good job with that.
We have to fundamentally rethink
Yes.
working conditions
Yes.
for frontline staff, right? Like,
Yes.
this is not a number of tweaks, right? Because, like, yes, we need more funding. Yes, we need more nurses and doctors, especially, family physicians, and nursing staff in acute care settings. But this needs to be a reworking. We
Yes.
need to do for our frontline healthcare workers what we want to do for our patients.
Yes.
Like, I remember
Exactly.
having a colleague who became very upset, and not at any one person in particular, but it wasn't at the group. It was she was venting at the system because she was forced to come in and work and do call while she was boiling over with a fever. Because there's this shortage of staff and no one was able to cover. There's something wrong with that system, right? Because if your patient walked in, you'd say, well, it sounds like you need a day off work.
Yeah. Yes.
If you're shaking with rigors, you know what I mean, or whatever.
I know.
Yet we don't do for ourselves. And
that's the problem.
We need to come together with a common voice and say, this has to be better. Because I'm not going to be able to perform my best as a physician if I am not healthy and thriving.
Exactly.
Right? And no number of protocols and mandates and new technology will fix any of this if healthcare workers are not happy and thriving. And I think, some US hospitals do this better. I'm not going to say the US healthcare system, because that's a disaster, if I can be perfectly blunt. But some US hospitals have really worked very hard to ensuring that their staff are thriving. And as a result, they deliver great care. And the other knock on and the other benefit is a feeling of engagement. Because when we talk about burnout in any work setting, one of the feelings or one of the symptoms of burnout is a loss of control, feeling like you don't have a meaningful impact. But if you are burnt out and exhausted and so tired you're struggling to drive home after a shift, how are you going to go sit on a committee? How are you going to write that courageous email demanding change? You don't have the bandwidth for it, right? We're too tired to even complain sometimes, is my reflection. I don't know, maybe I don't know what your thoughts are on that, Jayna, but sometimes I feel like we are almost just too tired to even vent anymore.
It's true. And when I'm hearing you, and what I think about, especially from the work that I do, is when we talk about resources are not limited to just supplies and equipment, even human personnel. It's about the lack of ability to contribute to this huge thing we call the knowledge pool. Because when decisions are made based on what is pulled from the knowledge pool. And only what goes in is able to come out. And so my dissertation work in epistemic injustice really talks about being able to contribute. And most healthcare workers right now don't feel like they have access to that pool, because the things that they need are not being provided, because the persons that are gatekeeping the pool, if you wish, who are making the policies, who are creating the processes for the organization, don't have the language that is going to satisfy the needs of your physicians and your nurses and your other allied healthcare workers. And so if you don't have that, then what's happening? these individuals are becoming marginalized, right? You're pushing them to the side. They don't have any say. If I don't have any say, eventually, what epistemic injustice does or leads to is I'm going to stop talking. I'm going to stop contributing. I'm going to stop giving any type of idea because why? You said it. I'm too tired. And nobody's listening. Nobody's hearing me. I don't see anything in here that corresponds with what I need. And so that's going to cause me to draw back. And that's called epistemic silencing because I'm pulling myself away. I don't want to talk about it anymore because I've tried that. Now nothing's working. And so now you get into meetings, and I don't know if you've seen it, right? And persons are just sitting there. And you're like, nobody's contributing, nobody's saying anything because that epistemic quieting is really the thing that's silencing their voices. And so the voices become quieter and quieter and quieter. And then what we have now is what we look at as quiet quitting, right? You're there,
It is.
I'm just doing the bare minimum, and that's all I'm gonna do, and nothing more. And once I do that, I'm just to satisfy what my contract says. I need to show up, I need to be here for 12 hours, and then I need to go home. And that's it. And you're not getting anything else out of me. And when that happens, that is dangerous for the organization. When your workers stop talking to you, when they stop contributing, that means you're about to lose some people. And so how do you now this is where
That's another warning sign, I think, for health leaders to pay
exactly.
attention to
Yes.
is when people start getting quiet because they're
Yeah.
feeling disengaged. That's a real learning for me.
And so that is creating this vacuum because now knowledge is not being exchanged here. And I'm not policymakers. I remember a story where an administrator decided to go out and purchase some chairs for a department, right? Went out, got these elaborate chairs, brought them into the department. Everybody was thinking, like, so what are these? Who do they belong to? Why are they even here? And feeling so proud of themselves, they that they did this thing, they got these chairs, and I don't know who they consulted with, but the chairs were useless. It was a waste of money. They didn't serve the space, they didn't serve the workers in the space. And so, why was it even done? Who did you consult? And when there is that lack of consultation, where I'm actually feeling, and this is where the credibility comes in with epistemic injustice, where I'm feeling like when I contribute information to you, you're literally hearing me and you're taking that information, you're seeing it as valuable, and you're acting on it. And somehow, when that's not happening, and I know epistemic injustice also deals with a lot of prejudice, and I can bring that into this play too, because if you have workers, we right now we're in a time where they are recruiting from abroad. So lots of foreign physicians, lots of foreign doctors, nurses coming into the space. And I'm going to say one thing about that, and then I'll finish my thought. Do you remember the commercial, the Febreze commercial? the nose blind commercial. Have you seen it? Like where they have the big sock, or the car looks like a big
Yeah, yeah,
dog,
yeah.
or the house looks like a huge ashtray full of old cigarettes. So I feel like in healthcare, there is what I like to call the nose blind effect. And what happens is when you're in an environment for a very long period of time, you become desensitized to the things that are happening. And when someone new comes in, their perception of that space is spot on. And what happens is when that individual comes into this new space and they're like, hey, why are you guys doing this? Like, what's up with that? What's up with it? Now they become the bad individual because we've been here a long time. What are you talking about? This place is working
This is
well.
our normal.
Yeah.
Even if
But
it's dysfunctional, it's
but
our
it's
normal.
dysfunctional. But it's dysfunctional, and it's not helping. It's not helping the environment. And I feel like if you bring someone in, don't be so quick to assimilate that
Love
individual.
that.
Be quicker to listen to what they are perceiving, because what they haven't been tainted by your system. They are fresh. Their eyes haven't been clouded. So when they walk into your healthcare organization and they point things out to you, be receptive in that moment, because
Even as subtle as an eye roll.
listen, be receptive. Don't disregard what
Dismiss
they're
it. Yeah.
saying,
I
because
love that.
they are there to help you through your blind spots, through your nose blind effect, because you have been in the stench for so long. And I'm just being very
You're
frank here.
being blunt. You're being blunt. But some of this is a real struggle.
Yes.
When you're being forced to discharge patients home that shouldn't go home, that stinks.
Yes. And so learn from that individual. Use what they're saying and ask them. This may be an opportunity for you to call those new people in when they bring that up. And rather than ostracize them, say to them, hey, listen, tell me more about what you're seeing.
Why does this stink to you?
Why
does this stink? In what specific way does this situation stink to you? And this is so powerful. And I think we got to wrap it up here.
Yes. Yes.
Which means we obviously have to get you back on the show, Jayna, because we're not going to fix the healthcare system in one podcast episode, and we're certainly not going to. I wish, but I mean, I think the wisdom that I'm getting from you on this is let's start to have some frank conversations. Let's stop pretending that this is just a short-term crisis, because I have watched many crises, and not just COVID, flu season, surges in population, an aging population, family doctor shortages. There's so many mini crises, and they're not that many.
Yeah. But
it speaks to a healthcare system that lacks any margin or redundancy.
Yeah.
Hospital beds across this country are 100% of capacity. Every jurisdiction in this country has a shortage of family doctors.
Yes.
And let's stop pretending that these are just minor or temporary issues. Let's start to be honest that the situation is bad, that we are all committed, or the vast majority of us are committed to a sustainable public healthcare system, but we need innovation, and we need to start with some very honest conversations within the health profession, and that includes our nursing colleagues. I think that's so important, that we shouldn't be pitting against one another for resources when this should be all of us coming together.
Yes.
And recognizing that we all play an integral role in keeping our system viable.
Yes.
And we all have a voice. And so let's just start with that. Like, let's just start calling it for what it is and have those honest conversations. And that it's not unique to one jurisdiction, that all systems are under pressure.
Yes.
And that it's got to get better. We just have to start to want something better than what we currently have.
Yes. Especially those in leadership. They have to have the will to make the changes. This is not going to blow over, and it's only getting worse. And so, as an administrator, as a CEO of a health region, whatever your capacity is in developing policies and processes, you have to sit down with the right people. And that is your healthcare workers. You have to have that conversation with them. And you have to not only listen, but be willing to implement the things that are necessary for the change. Because there's no point in us having conversations if that's all they will be.
Yeah, because eventually people will stop bringing it forward and we're back to the silence again.
Yes.
So
exactly. And
I love that.
So that's the healthcare system is precious. We need to acknowledge it. We need to nurture it. We need to love on it some more in order for it to get to that place where when we are in our 80s, the healthcare system will be just as robust, or even more so. And then we have a new slate of healthcare providers that love the job, that want to be a part of the profession, and that want to be engaging in all aspects of the healthcare system. And so we have work to do if we want to see this healthcare system last throughout all time. I should say.
Absolutely. So again, thank you so much for being here today, Jayna, because I mean, you saw me on the video. I teared up a couple of times talking about what we're struggling with, and to finally talk so honestly was, even for myself, good for the soul. So again, I am so glad that we met, and we look forward to having you on again to talk more about these issues, because you've seen it the whole way through the healthcare system. And now, with your educational background and consultancy work and coaching, you just have such a remarkable perspective on these big, big issues. So again, thank you so much, Jayna.
Thank you, Kevin, for having me. This was so much fun talking about the thing that I'm so passionate about. And I look forward to future episodes, podcasts, conversations about fixing our system.
Thank you so much.
Okay. Thank you, Kevin.
Thank you so much for listening to the Physician Empowerment Podcast. If you're ready to take those next steps in transforming your practice, finances, or personal well-being, then come and join us at phys-empowerment.ca, PHYS empowerment.ca, to learn more about how we can help. If today's episode resonated with you, I'd really appreciate it if you would share our podcast with a colleague or friend, and head over to Apple Podcasts to give us a 5-star rating and review. If you've got feedback, questions, or suggestions for future episode topics, we'd love to hear from you. If you want to join us and be interviewed and share some of your story, we'd absolutely love that as well. Please send me an email at kmilo@phys-empowerment.ca. Thank you again for listening. Bye.